It's a great pleasure to introduce our last speaker, Professor Steve Webb. Steve's a Senior Staff Specialist in Intensive Care at the Royal Perth Hospital. He's a Professor of Critical Care Research at Monash University. He's published extensively in many of those manuscripts that you saw. I suspect had Steve's, in Robert's presentation, I suspect had Steve's name on them. And very importantly, from an ACTA point of view, really conceived this whole concept. It's a great pleasure to introduce Steve. He's going to address us on what we don't know about the health and economic benefit of trials and registries in Australia. Steve.
Thanks very much, John, and thanks very much for the invitation. So my disclosures are provided so that they're on record. I was asked to talk about the economic benefits, the health and economic benefits of both trials and registries, but I have relatively little experience and understanding of registries, so I've taken the liberty of just restricting this discussion to the health and economic benefits of trials. If we think about things we know, there's a bit of a sort of a matrix. So there's things we know, there are things we know we don't know, there's a much larger group of things we think we know, and then there's a lot of sort of Rumsfeldian things that you don't know that you don't know. And I'm going to concentrate today on the things that we don't know, but also allude to some of the things about which I think we know, but we probably don't. And I'm also going to take the liberty of considering not just health and economic benefits, but also health and economic costs. If we're interested in the concept of return on investment from trial activity to the healthcare system, we need to have a consideration both of costs and benefits. And I think there are important unknowns associated with costs as well as benefits. And there are 4 of these elements that I plan to talk about. The first one is that we currently don't know how much of the care that's provided routinely in hospitals in the community throughout Australia is actually based on high quality evidence. Clinicians utilise evidence to make decisions. They frequently find themselves in a situation where there are more than one legitimate option for the decision that they face on a daily basis. And this involves the comparison of 2 or more treatment options that in widespread use are known or at least believed to be safe and effective, but it's simply not known which is the best option. And this defines comparative effectiveness research, these 3 criteria. And to a very large extent, one of the major gaps in terms of the health and economic benefits of clinical trial activity is we simply don't know the size to which this paradigm applies. And surprisingly, we have very little evidence about how much care that is provided is evidence-based. There's a review of the MBS schedule underway at the moment, and our Health Minister, Susan Lee, is on the public record as indicating of the 5,700 items on the MBS, only 3% of those items have been assessed or tested to see whether they actually work, are out of date or even harmful. So I don't know the legitimate basis of that claim, but at least as far as our Health Minister is concerned, there seems to be strong evidence that much of what is available within the healthcare system at the moment is not supported by high quality evidence, and that's an untenable situation. In my own discipline of intensive care, we had some of our registrars a few years ago evaluate the treatments provided to 100 consecutive patients and then identify from meta-analysis and consideration of randomised controlled trials what proportion of those treatments had been tested in high-quality randomised controlled trials to be shown to improve patient-centred outcomes. And only a tiny fraction of those interventions that we were using on a routine basis had been tested and proven to improve outcomes. The majority of what we do is supported by evidence that suggests that it improves physiological endpoints or surrogate endpoints, or it fits with the paradigm of how we think critical illness unfolds. But when the ANZICS Clinical Trials Group has done clinical trials, we've frequently found that the treatment that we predicted to work on the basis of physiological or pharmacological principles was either ineffective or harmful. It's very much the case that RCTs are to some extent, the ultimate, but also the only arbiter of truth about what works for the patients that we treat and we care about. And even when there are randomised controlled trials available, this is evidence from BMJ clinical evidence, of 3,000 treatments for which RCTs have been conducted, and even after the RCTs are conducted, for 50% of those treatments, the evidence is still considered equivocal and effectiveness is unknown. So within the paradigm of the healthcare system, it is very much the case that we're familiar with an evidence practice gap where evidence that we know about is not implemented into practice. But there's also a practice evidence gap where there's an enormous number of routine practices widely undertaken without evidence or without knowledge of their effectiveness and their cost effectiveness. And so you might ask, what do storks and babies have to do with evidence? Unfortunately, at least to some extent amongst policymakers, certainly not at the highest level of policy making, but perhaps amongst hospital chief executive officers and those sorts of levels, there's unfortunately uncertainty about where evidence comes from. And evidence doesn't come from storks, evidence comes from conducting randomised controlled trials. We really don't know the size of this problem. My personal belief is I think that this is a very substantial problem and one of the major drivers of a lack of sustainability associated with the healthcare system, Mark. And what we need to do is keep calm and measure it and sort it out. So the second thing that I want to refer to with respect to the health and economic benefits of clinical trials is we just simply at the moment don't know how many patients are participating in clinical trials. And it doesn't actually have to be this way. This is data from the NIHR annual report last year, and this is a number. They actually can count down to a single individual that there were 618,453 patients enrolled in portfolio studies within the NIHR. I have done the crude maths on this, and it's certainly a far higher proportion of patients on a pro rata basis enrolled in clinical trials in the UK than occurs in Australia. Within my own discipline, the ANZIC's Clinical Trials Group conducts once or twice a year a point prevalence study focused on different conditions. But one of the questions that we ask every time we conduct a point prevalence study is what proportion of patients are enrolled in a randomised controlled trial? And even though John has very kindly alluded to the impact of trials conducted by the ANZIC's Clinical Trials Group, we're only recruiting between 2 and 4% of prevalent patients into randomised controlled trials. So the capacity to generate better outcomes for patients is certainly in no way limited by the number of patients who are available to participate in trials. And what we do know from childhood cancer, and I think Cathy Cole will speak later today, is what happens when a discipline is able to combine the presence of a tractable disease like acute lymphocytic leukemia combined with a very high proportion of patients being enrolled into clinical trials. And we see the miracle associated with taking a disease that was untreatable in the 1940s and 1950s to a condition now as a consequence of a very large proportion of children with this dreadful disease being enrolled in a clinical trial, now having survival, long-term survival with 80% of patients having essentially a cure of their disease. But this occurs in a framework where the default arrangement for children with cancer is that they participate in a clinical trial of best current therapy against the option which is considered most likely to be better. The third thing I want to refer to in terms of things we don't know about the cost and benefits of clinical trials really relates to their costs. In the last couple of years, IPA undertook a process to try and, in a very sort of detailed cost accounting way, provide costs for undertaking clinical trials. I was involved in that process. I found it a relatively dissatisfying process. And part of, I think, what made me feel uncomfortable about it was that in terms of the work that we do as investigator-initiated trialists, there's no taking into account the enormous amount of volunteered time that is provided by investigators, research coordinators, and site investigators. We don't have a good understanding on the very real cross-subsidy that exists between hospitals and healthcare systems, or between commercial trials and the investigator-initiated sector, and we don't understand the incredible importance of how much of the goodwill that comes from the 10,000 clinicians that are associated with the ACTA networks contribute in terms of conducting this work. So I think we need a much better understanding of the true costs of conducting trials to be able to understand an important part of the fraction that is associated with return on investment. Another thing I want to refer to, and take this opportunity to do so, is the extraordinary cost that's associated with the regulatory environment in which trials are conducted. There is literally a mountain of paperwork, a mountain of delay that's associated with the regulatory requirements for clinical trials. That has a very substantial impact on budget. It has a very substantial impact on how quickly trials can be conducted and what can be conducted. And there's an unmeasured impact in terms of trials that are never conducted because of the regulatory burden that's associated with trials. This is a personal view, but it's my view that, at least for comparative effectiveness research, the provision of information and consent should be matched and correspond to the same level of provision of information and consent that would be associated with delivery of the same interventions in a therapeutic context. So lastly, I get onto the fourth element, and this really is the most important one. It's the Banksy elephant in the room, and it really does refer very much to the return on investment study that Rob referred to earlier. And it relates to the critical importance of networks being able to demonstrate the impact of the work that we do. At the moment, our core business has been to conduct clinical trials. And unfortunately, when it came to doing a return on investment study, we weren't actually able to identify much in the way of work to demonstrate whether or not the results of trials conducted by networks in Australia were actually being implemented into practice. And I do think if there's one message that we take away today, it is that we need to move from just doing trials to also being able to do observational studies before trials are conducted and after trials are conducted to know if the results are implemented. We also need to form linkages and take advantage of the expertise associated with people whose expertise lies with implementation science, so when we discover that important results are not being implemented for patients, that work can be done to increase the proportion of patients who are receiving the care that should be occurring as a consequence of the new knowledge that's created. When Health Outcomes undertook the return on investment study for the 3 networks that Rob presented, a range of assumptions had to be built into those models. And a key assumption related to whether or not the results of the trials were actually implemented. The study made a presumption, an assumption, that there was 65% implementation. But the value that's created by our trials is critically dependent on the size of that number. I'm sure that for some ANZIC's clinical trials group trials, our implementation is 100%. And for others, I'm not so sure. But in no situation do we know the actual extent of that implementation. So I think to some extent we need to recognise that as clinical trials networks we have a responsibility to the healthcare system, and we need to see ourselves not so much as an ivory tower or academic enterprise, but a deeply pragmatic and practical component of the healthcare system. We need to consider ourselves and be seen as not just an academic activity that generates trial results using scientific methods, but a core key component of the research and development enterprise that's associated with the healthcare system. In terms of things that we think we know, I think we think that we implement the results of our trials, But it's vitally important that it's no longer sufficient to think we implement. We need to know if we implement. And then we can use that data not to model return on investment, but to actually measure it and profoundly make a case for why more clinical trials should be done. So by way of conclusion, I think there are 4 important elements. First, we don't know the size of the practice evidence gap. Secondly, we need to know how many patients are actually in clinical trials and measure our activity. Thirdly, we need to have a much better handle on the real costs of doing our trials. And lastly, we must know whether or not the results of our trials are implemented. Thank you, John.